Hello, my name is Jonathan Finoff, and I'll be talking to you today about ultrasound-guided interventional procedures of the hip. I don't have any disclosures that are relevant to this presentation, but I do have a disclaimer. This presentation is not meant to be a comprehensive review of all ultrasound-guided procedures around the hip, but rather the objective of this presentation is to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships. With that in mind, we'll be covering an intra-articular hip injection, greater trochanteric bursal injection, and gluteus medius and minimus tendon and peritendinous injections. So for an intra-articular hip injection, the patient will be in a supine position with their hip in neutral rotation. Frequently, they'll be slightly abducted at about 20 degrees of hip abduction. I use a low-frequency curvilinear array transducer, and the needle will typically be a 22-gauge, 3.5-inch spinal needle, but the length of the needle is variable based on the patient. The transducer should be placed in an anatomic transverse oblique plane, with the cephalad portion of the transducer a little bit more medial and the caudal portion of the transducer a little bit more lateral. This is in plane over the femoral head and neck. The technique for this particular procedure is an in-plane or long-axis approach, so the needle will be collinear with the transducer, and the needle will traverse underneath the transducer in an inferior lateral to superior medial direction. The target is going to be at the femoral head-neck junction. So as you can see in this arrow, the needle will come down through the iliopsoas tendon and muscle, through the joint capsule, with the target being that femoral head-neck junction. This demonstrates the procedure. You can see the needle tip coming down. The transducer will be repositioned over the needle tip, and there it went into the joint. From a pearls and pitfalls standpoint, you want to identify and avoid the femoral neurovascular structures, including the ascending branch, the lateral femoral circumflex artery. So here are the femoral neurovascular structures, and then I've moved my transducer over the femoral head and neck junction, and here you can see that ascending branch of the lateral femoral circumflex artery. So one more time, there were the femoral neurovascular structures. Here's that ascending branch of the lateral femoral circumflex artery. For a greater trochanteric bursa injection, you want the patient in a side-lying position with the painful or symptomatic side facing towards the ceiling. You can use either a linear or curvilinear array transducer depending on the body habitus of the patient, and I'll often use a 22-gauge 2.5 or 22-gauge 3.5-inch spinal needle. The transducer will be placed in an anatomic transverse plane over the greater trochanteric area, typically more in the posterior region over the lateral facet. The needle orientation relative to the transducer will be in the long axis. This is an in-plane technique. And the needle will traverse from posterior to anterior. What you want to target is the tissue plane between the gluteus maximus and iliotibial band, which are superficial, and the gluteus medius tendon, which is deep. So in this picture, this is the greater trochanter. This is the gluteus medius tendon, so we're over the lateral facet. Here's the iliotibial band with the gluteus maximus attaching to it. And you can see this hypoechoic line in between the gluteus medius and the IT band region. And the needle should come from posterior to anterior and be placed in that hypoechoic line. So here's a picture of the needle in that greater trochanteric bursa with fluid going into the bursa. Here's another picture of that exact same injection. You can see the iliotibial band being lifted off of the gluteus medius. Sometimes you can use slight rotation of the transducer to bring it a little bit more in plane with the gluteus maximus fibers, which can increase the conspicuity of the bursa. The injectate can be anywhere between 4 and 10 cc's of injectate, depending on your goals of the procedure. Gluteus medius or minimus peri or intratendinous injections are performed with the patient again in the side-lying position with their symptomatic hip facing towards the ceiling. I typically am going to use a linear array transducer, but depending on the patient's body habitus, you can use a curvilinear array low-frequency transducer, and I'll often use a 22 gauge 2.5 inch or 22 gauge 3.5 inch spinal needle. The transducer should be in plane with the fibers of your target tendon, whether that's the gluteus medius, which would be more posterior, or gluteus minimus, which would be more anterior. And the needle, relative to the transducer, will be in the long axis or longitudinal. So this is an in-plane approach. The needle will traverse from cephalad to caudad into the tissue plane of choice. For peritendinous injections, the tissue plane will be between the IT band and the underlying target tissue, such as the gluteus medius in this picture. So here's the iliotibial band, more superficial, the gluteus medius deep, and here is the tissue plane between the two. Or if you're doing an intratendinous injection, then the actual needle will go into the tendon itself. Here is a fenestration of a gluteus medius tendon with significant tendinopathy. There are no significant neurovascular structures or other anatomic structures that you need to avoid or be aware of in this area. The injectate completely depends on what you are injecting and where you're injecting it. In the peritendinous region, it can be between 4 and 10 cc's, whereas in the intratendinous region, you're typically going to be doing an injection of 2 to 3 cc's of some type of regenerative compound. And that completes the common interventional procedures of the hip.